So understanding a little bit about what happens to the respiratory system during sleep is a pretty important feature of this discussion. The respiratory tract shares a common canal with the GI tract, which is related to swallowing issues. And again, that's a very important issue because with swallowing is the methodology for nutrition. And so as patients become a little bit weaker, we start to see difficulties with swallowing. And because of the proximity of the airway to the GI tract or the esophagus, swallowing becomes an important thing to kind of manage and follow over time. And obviously to develop strategies to make swallowing safe and effective so that patients are able to maintain nutrition, et cetera. We'll talk a little bit about scoliosis. Perhaps in the last talk you also had some discussion about that, but I'll take the perspective of how it affects the respiratory system. And then something that we see and interact with frequently are our colleagues in cardiology, where patients with muscular dystrophy also have some impairment of the muscle of the heart. And as a result of that, we have to sort of be on the lookout for issues that develop related to their heart function. So this is basically a diagram of the respiratory system. And on the left side, you see basically the structure of the pump. It begins with the upper airway, which is the nasopharynx, the trachea, and then gives way to the thoracic cage, which is constituted by the ribs and spine in the back. And those are important because without the rigidity of the spine and spinal cord, you would not be able to actually inflate the lung. And then you see at the bottom of the diaphragm, the diaphragm, which is the most important respiratory muscle that we have. I'd also point out that, not really characterized here, but there are accessory muscles of respiration that also are important in coughing and inspiration, et cetera. And those are the muscles that go between the ribs and also the abdominal contracting muscles. So that's kind of a general look at the respiratory system as a pump. And on the left side of this diagram is really the business end of where gas exchange occurs. This is where oxygen comes in, interfaces with the blood system, and there's uploading of oxygen from the environment into the bloodstream. It's also where carbon dioxide is downloaded. So that's sort of a characterization of the respiratory pump at a high level. And so when we think about what's going on with the respiratory system, it's really accomplishing a few things. Ventilation delivers oxygen, gets rid of carbon dioxide, which is the waste product of metabolism. So, this whole thing starts around the fact that to be a higher organism, you have to develop an efficient energy system. And the way we do that in humans is by using oxygen as the method of transporting electrons that drive metabolism at the cellular level. So by being a higher level organism, then you have to figure out more sophisticated ways of generating lots of energy. And so oxygen is that vehicle. The consequence of the metabolism of oxygen is the development of carbon dioxide. Carbon dioxide is an important feature because you've got to get rid of it, and if it builds up, develop all kinds of untoward things like vasodilation in the brain, which makes you foggy and groggy and feel ugly in the morning, and as well as is also having a significant effect on acid base, which is important. So the system also gets oxygen, as we talked about, into the energy pathway. It's crucial for sustaining human life. It also has a very important function if you think about it. So we're talking about the external ambient environment being introduced in this very sensitive place, which is the lung tissue. And you need to have some sort of way of filtering things out and cleansing the lungs. So we inhale on a daily basis lots of noxious things. And the respiratory system has an elegant way of filtering it out, starting with your nasopharynx, and then also including the respiratory epithelium down deep in your lung, which has a little bit of like a glue-like flypaper type substance on it, the mucus. And then it's moved back, takes all of the particles and noxious things that we inhale and moves them out back towards the trachea, where we then typically will cough them out, or we might not even be aware of it, but if they rise up above the vocal cords and then we swallow them, if we're not coughing. So the cleansing effect of the lung is crucial for maintaining a sort of a clean environment for gas exchange to occur. Part and parcel to that is the lung functions as an immune surveillance mechanism, which means that it has capabilities around affecting inflammatory responses that are beginning to occur in the lung. So that could be because of an infection or, again, some noxious chemical that we inhale. It has a very important effect on being able to handle noxious stimuli, whether it's infectious or otherwise, and being able to curtail the negative impact at the lung level. So immune surveillance is a critical function of the lung. Without it, we'd have lots of infections and lots of various inflammatory responses that would be bad for the lung. It also has an hormonal effect that it does, and many people don't recognize the lung necessarily as being an endocrine organ, but it does have neuroendocrine properties where it takes chemicals and changes their behavior, neutralizes them, metabolizes them, and aims them so that you have proper immune surveillance, et cetera. So it also functions in that capacity. So the respiratory pump, as we were talking about, begins with developing an open upper airway, and all the features there include the nose, mouth, pharynx, vocal cords, trachea, bronchi, and alveoli. So that system has to be open. So, for example, if you're snoring at night, it interrupts this system. So the pump has to be contiguously open for air to flow into the lungs. The other important feature, as I mentioned earlier, is you have to have a rigid external pump that when it expands and contracts will flow air in and out of the lung. And so that's accomplished by the spine, the ribs, cartilages, et cetera. And then you have to have some sort of a driving force, the piston, if you will, which is provided by the rigid structures connected to moving structures, which are the muscles. The diaphragm, which is the most important inspiratory muscle, and then the accessory muscles of the chest wall, et cetera, that are very important in driving explosive cough. Cough is really an important feature in terms of cleansing the lung. So let's see. And then the two main functions that we see are ventilation. Maybe this would have been better said, carbon dioxide excretion and oxygenation, or uploading of oxygen. And those are the two main things that the lung was designed to do, although it needs a supporting cast to do it effectively over time, which we mentioned. So again, here's just another schematic of how it's working. You see on the left side the rigid chest structures, the ribs, et cetera. You see the lung, and then you see the diaphragm at the bottom contracting downward, which creates a suction around the lung that allows air to flow as long as the rest of the conducting airways are maintained open. So for example, in obstructive sleep apnea, the diaphragm contracts, but because the airway closes up above it, what happens is there's a complete obstruction and there's no airflow that can occur. And then on the right side of this diagram, you see an expiratory event where the diaphragm relaxes and allows the chest to go to a neutral position, which causes air to go out. And if you force the exhalation, then you actually reduce the volume even more and get additional flow to occur. So in muscular dystrophies, there's some challenges that develop. First of all, as weakness develops, you can begin to see that the amount of volume and flow begins to become reduced. And as we mentioned, there's this intimate relationship that it has with the structural or rigid framework of the pump, that is the ribs and spine. And so, as you might guess, if you change the conformation of the relationship of the spine and ribs, you could potentially affect the volumes. So having the development of scoliosis, as we know, will negatively affect the volumes that we develop. So that further exacerbates the loss of the respiratory power that you're getting from the muscles. With that comes the next issue is really mucus removal. And if you impair the expiratory power, then you're going to impair the relief of secretions that build up. And the problem with retained secretions is that it leads to infection. And if you think about it, if you have a full obstruction of a bronchial tube deep down in the lung, that area where the bronchial tube is supplying flow and oxygen to will no longer be working. So you develop an inefficient lung with reduction in oxygen in your blood, et cetera. So secretions, when they build up, can basically block the flow of air to the functioning part of the lung. So that's a pretty important piece of this. Another thing that we talked about just briefly was swallow. It shares the common upper airway, and when the swallow functions become weakened, which include clearance mechanism, just like the lung, you leave behind a residue of material that has potential for getting into the lung when the next breath is started. So having swallowing integrity is pretty important. And then finally, to make all of this work, you can bring in all the air that you want, but you have to have good circulation through the lung in terms of blood flow. And so we have to be on the lookout for the development of anything that would impair a proper cardiac function. So reduced cardiac performance will compromise the delivery of oxygen to all of the functioning muscles and organs, and as a result of that can lead to insufficient organ function. And then the other thing that happens with the heart is, and we'll talk just a little bit more about it, is electrical instability, which is basically changes in the heart rate, fast heart rates, slow heart rates, that sort of thing. And again, it has a direct relationship to how the cardiac performance is being visualized, and as a result of that, the actual delivery of oxygen to tissue. So so if you're looking at 60,000 feet, what we see with the development of respiratory insufficiency is the very first place where you can start to see problems is when patients are actually going to sleep. And REM sleep is interesting. REM sleep stands for rapid eye movement sleep, and it's a very interesting physiologic moment that we experience when we go to sleep. Because during a REM sleep, the only muscles that are working in your body are your diaphragm and your eyes. Therefore, they call it, you have this rapid eye movement in sleep. But those muscles and the muscles that drive the diaphragm are the only ones that are functioning, which means that the rest of your body is actually paralyzed during that period of time. So you lose some of the effect of the inspiratory and expiratory muscles during that phase of sleep. And so as the diaphragm gets a little bit more compromised, weaker, you begin to see elements of hypoventilation, which is, hypoventilation means insufficient ventilation occurring because you just don't have the same volume that you would normally be driving. So REM sleep is typically, and we see this in all kinds of situations in adult males, et cetera, where the very first thing that you see is interruption of proper function during REM sleep. As the weakness gets a little bit worse, we see the effect being sort of leaking into non-REM sleep, and we also see the development of upper airway obstruction because as we become a little older, we start to see this as a natural phenomenon in the background anyway. So obstructive sleep apnea, which is interruption of airflow in the upper airway, also becomes part of the physiology that we see. And of course, it migrates as weakness develops, as scoliosis develops, as patients become wheelchair bound, that daytime ventilatory insufficiency is perceived, and then on to the final situation, right? So I think this is sort of a generic slide looking at neuromuscular disease in general. So this muscle weakness begins, you start to see it affect on the left side, inspiratory function. The maximum inspiratory pressure, the PI max, is associated with a drop in the size of the volume of inspiration. Fatigue starts to set in, and then you begin to see the muscle not being able to keep up with CO2 or carbon dioxide excretion, so the carbon dioxide starts to rise in your blood, and as a result of that, the oxygen begins to fall. In the middle panel, you have the effect of muscle weakness on the expiratory side of things. So what happens is vital capacity is a maneuver we use to measure lung function, and it's probably one of the simplest, fastest ways to sort of describe what's going on with a person's respiratory mechanics. And the vital capacity begins to fall as expiratory muscle force is reduced. The way we measure it is a thing called the maximum expiratory pressure, or the PE max in this case, and then expiratory flows, and the volume that's left in the chest at the end of an exhalation, which is called the expiratory reserve volume, falls. This is kind of technical stuff, but mainly that when you lose the expiratory force, your lung begins to shrink down in volume. As a result of losing the expiratory side, though, a very important bottom line occurs, which is that your functionality around coughing becomes compromised. And that's a very important element that needs to be monitored and dealt with. Ineffective cough has got many recriminations that we have to be aware of. It leads to accumulated secretions, infections, the collapse of lung when the airways become occluded or blocked. The part of the lung where that bronchial tube is supplying air basically has the air extracted from it, and the lung will collapse. And that leads to a vicious cycle of recurring infections, et cetera. And then finally, on the right side of this is the implications of the upper pharyngeal muscles that become weak, where you start having more and more trouble clearing your secretions. And when you're swallowing, completely evacuating any of the food residue that's left in your mouth or in your pharynx after you've had a swallow. And that leads to aspiration, which is an important feature to be aware of and actually to manage aggressively. So basically, to sort of when patients come in, we should be kind of thinking about several things. The routine evaluation of the respiratory function, sleep-related issues, nutrition, swallow, cardiac function, et cetera. And so during a routine evaluation, we try to get an assessment of how the respiratory pump is functioning. We assess muscle strength, cough efficiency, gas exchange. We use spirometry to do a lot of this, as well as maximum inspiratory, maximum expiratory pressures. CO2 capnography is really just a tool for looking at whether the blood shows signs of elevating that carbon dioxide. It's an important feature to be aware of. Carbon dioxide rising in the blood suggests that you're losing the ventilatory efficiency that you need to maintain homeostasis, or basically constant pH and that sort of thing. And then we can also use arterial blood gases or venous blood gases. So for typical evaluation, it's important to be seeing a respiratory physician every 3 to 6 months, depending on your level of stability. And we typically would look at spirometry, MIP and MEP measurements, and we do oximetry on every visit a patient comes in at. And then also looking at things that evaluate the carbon dioxide buildup, either with the thing called capnography or arterial blood gas. And then, depending on the situation, we'll get an annual polysomnogram if we are worried about the development of a sleep disordered breathing syndrome. So the pulmonary function tests that we do, basic spirometry, which I'll do a little bit more with, the pressure measurements, both the MIP measurement, which assesses best the inspiratory capability of the muscle, and then the maximum expiratory pressure, which tells us it's probably the best predictor of cough efficiency, and then the carbon dioxide around ventilation. So if you've been in the doctor's office, you might remember having blown very hard as you can, into a thing called a spirometer. And on the left side of this is the starting point. You see this peak that occurs going northward, which is the expiratory phase or limb of what we call a flow volume loop. And so the point 0, which is right here, would be the point at which we begin to maximally inhale. That's also the point where we measure the maximum expiratory pressure. And then on the other side of this, which is you fully exhaled, you have the point where we would measure the maximum inspiratory force when the patient takes a deep breath in. So this is a typical flow volume loop that we get on a regular basis. And then this panel shows, on the far right, shows a normal lungs flow volume loop. The one in the middle, which is significantly diminished, is an age-matched controlled patient with muscular dystrophy, age 18. So you can see that the flow, both on the expiratory and inspiratory sides, is reduced. And then if you overlay that on the far left, you see sort of that the muscular dystrophy patient has less function than the age-matched control. So that's what we're looking for when we do these tests. Some important milestones. The forced vital capacity is a good one to get a general sense of what the prognosis looks like for a patient. And when it's less than a liter, we become increasingly concerned about things where we're actively recommending some sort of assistant ventilation. The FEV1, when it becomes lower than 20%, and FEV1 is the amount of flow that occurs after 1 second. So it's kind of a technical term, but we look at it as a measure of ventilatory efficiency, and it happens that when it's less than 20%, we should be very aware of what's going on with carbon dioxide. And if you think about it, it's basically saying that as you're getting to that point where you can't generate enough of a forced expiratory maneuver, then you're likely to be seeing the carbon dioxide rise in your blood. So this has a predictive value that we pay attention to. And then the maximum expiratory pressure is also an important landmark because it is a measure of cough efficiency. And when you can generate 60 centimeters of water or more, it's just the measurement parameter, we find that patients will maintain an acceptable cough efficacy. Whereas when it's less than 45 centimeters of water, we need to really start thinking about adding something like a cough assist or some other form of assisting patients in getting rid of their secretion. So these are important milestones that occur. And then this is me in the morning. I lifted this. It's a sleeping disorder, and I think they forgot a little piece of it. So I've got this terrible sleeping disorder where I have a nightmare where I have to wake up every morning to do work. I have a lot of days like this. Anyway, sleeping in muscular dystrophy is a really important thing. Like, so many normal patients and patients with other diseases, sleep is an incredibly important time, but it's also extremely volatile. And we see things like patients developing sleep apnea and other sleep disordered breathing syndromes, and we really need to spend more time about it and in evaluating it and treating it. And so in the patient with muscular dystrophy, there is a correlation with the development of becoming wheelchair bound and the increasing number of situations where patients are underventilating, or they're frankly obstructing, or they're developing obstructive sleep apnea or hyperventilation. And you can see this in the way patients come in and they're talking about how they're feeling, and all of a sudden they're saying, I don't feel rested when I get up, and I got a headache in the morning, and I feel like I was drinking and I haven't had a drop, and they just generally don't feel well. And that has to do with the fact that, first of all night long they're having episodes where they're waking up as a consequence of underventilation or obstructing. And then as a result of that, their CO2s are rising, which causes vasodilation and the morning headache. And in addition, you're getting things like, because of a lot of these episodes where you underventilate or obstruct are broken by the release of epinephrine. They are surging blood pressure, and they're having other things that are occurring that like arrhythmias, which are changes in their heart rhythm during sleep, all of which are not good in anybody. So patients wake up feeling bad. And one of the things that we can see is that when they do a sleep study, we're watching their brain waves, and we can see that they will have repetitive awakenings. And when we say awakenings, they may not be aware of that, because we make our definition based on changing electrical waves in your brain. And so going from, say, deep sleep to light sleep to us as an arousal, you might not appreciate that. And you may never get awake enough or long enough to sort of have it ingrained in your memory that you actually woke up. When we see a bad sleep apnea patient, we'll see that the arousal index goes way up. So it's important. And then sleep apnea and sleep hypoventilation are common. So, and periodic limb movement, which is a repetitive behavior that occurs. These are all things that can occur. So this is a panel that shows that. The third panel down shows the airflow, which is where you see the airflow stopping and then becoming completely absent. And that's associated with the fourth panel, which shows the volume decreasing. And then the fifth panel, which is actually showing that the lung is trying to ventilate, but there's no flow occurring. So that's typical. And this is when you're happy. I think there's supposed to be a smile there because the guy's well treated. So that's what you would do, is you would manage it with some sort of a CPAP or BiPAP. Nutrition is another thing, but I'm getting the high sign that I got to wrap up. So we'll just leave it that, like in any situation for a human being, proper nutrition is important. Swallowing is an important one, and I'll go through this very, very quickly, but we need to be aware of the various levels of swallow, from initiation of the oral intake through these pharyngeal phases, et cetera. And when things start becoming impaired here, we need to figure out how to safely feed patients, which can have implications about speech training, and then also even supplementation with tubes that can be directly put into the stomach. Maintaining nutrition is key, though. So I guess, oh, wait a second. I think you talked a little bit about this before, so I'll go through that quickly, or pass it. And then just the issue of making sure that there's a cardiologist that becomes involved as the patients age a bit. And that's because many patients with MD will also develop a bit of a cardiac insufficiency syndrome, and that has repercussions on the pump capability as well as the electrical capability. And the good news is that it responds to the same successful medication regimens that we use in adults who've had heart attacks and that sort of thing. So there's important therapy that works, so we shouldn't forget that. And I have to deal with that on a regular basis, so I try to make sure that our patients are interacting. And as you see, this is really a multidisciplinary medical team that takes care of patients with muscular dystrophy, and the cardiologist and gastroenterologist and nutritionists and infectious disease and others sometimes get involved with this, and I think it's important. So with that, I'll close, and then if there are questions, hope I didn't go over. Yes, ma'am. Yes. Yes.
Without much success.
Yeah.
Really having trouble sleeping.
Yeah. Well, okay, so I'll tell you a little personal story. So don't tell anybody, but my wife made me do a sleep study. And I hate her for lots of reasons, but that was one of them. I later, I married smart, so I won't say that it was a bad choice. But so I think that the point is that this is kind of a foreign device, and it took me 6 weeks. So the very first question is, or the suggestion when we're dealing with patients that need to do some sort of an intervention at night is it's got to be a college try. And I know most of the patients in this room probably are very well accustomed to doing college tries around their medical care, but that's a good start. And then I think it's a matter of trying to work through, there are many different devices, and what I always try to talk to our patients about when we do this is to make sure that we are meticulous about going through the different masks, the way they're applied, and doing things like that. Wearing masks during the day. If they have, like some kids or some adults, anybody has some, they may have a phobia about putting anything on their face. So sometimes it's as basic as wearing it, watching TV, just the mask, not even connected to anything, just to get them acclimated. But over time, what happens, in my experience, what happens is when you really start to need it, there's that moment where you're doing it. Maybe you're wearing it during a nap as opposed to at night, and you fall asleep with the thing on. And the next thing you know, you actually wake up feeling a little better than you did before. And so you're looking for those opportunities, but you have to it's a fussy business, but I think it's worth staying with it and trying different things, different pressures if you need to try to make it successful. There are lots of opportunities to try to overcome, reticence about using it. Has to be comfortable, though. Yes?
I have a question about for swallowing. When can I know that I'm actually getting the symptom and report it as soon as I know? Because by the time you can actually figure it out, it might be too late.
Yeah. So the question is about when to be concerned about swallowing, right? And what can you do to assess it? That one is actually a fairly simple one in the sense of the way we evaluate it is with a basic swallow study, usually with a sleep pathologist or a speech pathologist. And the value of the speech pathologist is twofold. One is they participate with the radiologist when you do a swallow study. And if everybody doesn't know what the swallow study is, it's basically you go to the radiology department. They turn you sideways so they can watch through a fluoroscopy beam how your swallow goes. And the radiologist goes, I see the tongue, I see the structures, et cetera, and they say, yeah, everything looks okay. But the speech pathologist is an artist. He is going to tell you, basically, when you take food, how does it go down? Does it go down quickly? Is it impaired or delayed, which happens when we get muscle weakness? Once it gets down into the hypopharynx, the lower part of the pharynx, if you think about the vocal cords, they sort of are like the bottom of the shower, where the there's a drain and the shower floor is there. In order to be safe, when you swallow, the vocal cords lift up out of the shower panel, if you will, or the bottom, right? And protect you so that there's no spillage into the lung when you take that breath. So the importance of the speech pathologist is to identify all of those physiology variables that are incumbent on an important swallow. And they can teach you, the other part of this is it's not all or none. So some patients may be close to aspirating, but with a few tricks, like double swallowing, tucking your neck, not using straws, thickening the fluids, et cetera, they can delay having to put in a gastric tube for a long period of time. And then even if the tube goes in, we will have some patients who kind of do a combination. So we kind of have this notion of they eat for gratification, but they get nourishment by the tube. So the bulk of calories go in this way, and if they want to have something this way, depending on what the swallow integrity looks like, then we can actually do something like that, right? And so there's a number of ways of handling the problem. What you don't want to do is get into a cycle where every time you sit down and eat, you're challenged to keep things out of your lung, and you start seeing recurrent infections occur, secretions build up, saturations go down, the oxygen in your finger, and it becomes dangerous to eat, right? So there's a very heterogeneous continuum where we try to get the best outcome for the patient. And the best outcome is determined by the patient, right? So if they like to eat, we try to keep that going as long as possible, but if we need to, we can take care of business giving nutrition through the feeding tube. Did that answer the question? Yeah, okay.
Need to jump in, but Dr. Browser's going to be here even in the afternoon too, if we want to save the rest of our questions for later on.
Sure, I'm happy to do that.
And he has another session too
Yeah.
for the later, more advanced stages
Right,
of pulmonology.
right.
So.
Thank you.